Hello. This presentation is going to be about Chapter 4 in the ATI Manual in the Leadership and Management text, and it's about maintaining a safe environment. Maintaining a safe environment for your clients and their families is a major nursing responsibility. We're going to go through the major categories and what each of those means in actual practice. The categories or the things we're going to talk about have to do with the cues and competencies, infectious and hazardous materials, safe use of equipment, accident and injury prevention, home safety, and ergonomic principles. We all know about the 1999 report by the Institute of Medicine that talked about preventable injuries and deaths to patients, and many of them were identified as system problems. And so all colleges of nursing, as well as the environment, have worked on making the environment much safer for patients, and we're going to talk about all of those and your responsibility. Let's first look at the cues and competencies. You've been practicing these the whole time you've been in nursing school. First, safety. That's your responsibility as the nurse to minimize any risk factors that your patients might encounter that can cause them injury or suffer some kind of accident. We're going to go through what that means for the environment. Patient-centered care. We talk about that all the time. If we put the patient at the center of every decision we make, at the level of the unit level, at the patient care level, all the way through the top to the CEO of an organization, if the care and the decisions are always made based on what's best for patients, then the outcomes are always much better. Evidence-based practice. We talk about that all the time. That we base our care and all the things we do for patients on evidence, the latest evidence that we can find, that we have quality improvement, not just as an afterthought or something that we do once a year based on requirements, but that in everything we do, we're always looking at a better way to do it. And we work on teamwork and collaboration. We're going to talk a little bit about interdisciplinary teams, which you've had some exposure to, and how that concept, teamwork and collaboration, really helps to keep patients safe. So let's talk about some specifics. Let's first talk about infections and hazardous material. It's always the nurse's responsibility to ensure that everything that they do decreases the chance of the patient either having a worse infection or getting an infection. Always know the categories of precaution: standard, airborne, droplet, and contact, what that means, how that means infection can be transmitted in bacteria, and what you need to do and where in order to keep your patient safe. And so you need to look that up so that you ensure that you know what that means. We all know that one of the best things that we can do is hand hygiene, in and out. Either use the hand sanitizer or actually wash your hands. We also, when we're talking about hazardous materials, everyone needs to know where the material safety data sheets are, or the MSDS. At Methodist, and I think even at St. Francis, it's on the computer where you can pull it up and look at it at a moment's notice. You should know how to look that up and how to search through it for what you need. Now, when it comes to equipment, we need to know there are a lot of equipment failures. We need to know how to use the equipment safely, how to clean it safely. If it needs to be plugged into, at the Methodist, a red outlet so that if the power would go out, the generators that hook to that keep it running. So we need to know when it's not working properly and when we need to take it out of service. And so those are the things I'm talking about for the nurse's responsibility, about the red outlets and taking it out of service. I want to go back and just mention a couple things when it has to do with hazardous materials. Some I want to remember to talk about is what kind of bags that you put different things in. They're usually marked. And the whole idea of retractable needles and the one-handed recapping. Those also decrease the chance of infection for you and keep it safe for the patients also. So let's talk about accident and injury prevention a little bit. Accident and injury prevention is a major nursing responsibility. Actually, this entire content is a major nursing responsibility. And how do we prevent accidents and injuries to our patient? Well, the first thing is we have to realize we have to be able to assess our patient's ability to protect themselves. Because if our patients can't protect themselves, we need to put interventions into place to help them. So Assessment is the first major nursing intervention, and we need to look at age. We know older clients, very young clients, um, their age has a definite impact on how they can keep themselves safe. What about mobility? Falls are a huge risk in the hospital, huge risk even in the home environment. That can take a otherwise pretty healthy patient. They have a fall, break a hip, end up in the hospital, end up with pneumonia, and then sometimes have a death associated with that. So falls and what they can do to the patient is a major um, area to assess. So mobility, cognitive and sensory awareness, how do they perceive their environment? Emotional, we know that people who are very, very upset or in an altered emotional state don't really take care of themselves. And lifestyle and safety awareness, do they know the things that they're doing um, that are harming them or keeping them unsafe? And as far as what we must be aware of, I talked about assessment, but procedural and safety guidelines. What are the safety guidelines for where you are working as far as bed alarms and how often you turn and check patients? And um, because injuries also have to do with not turning and patients getting decubitus. Those are also our injury prevention measures. Protocols for responding to dangerous situations. Um, a perpetrator in the unit or in the hospital, knowing security plans, and then how you document and understand incident reports. So the first thing we're going to look at is falls. Leading safety priorities is what we're going to look at. First one is falls. The word for falls is prevent. Um, it's much better to prevent than to go through all the things you're going to have to do after. And so we already talked about that. Huge assessment to prevent and figure out what you need to do for your patient. On the hospital and all hospitals, patients have a fall risk assessment that they do when they are admitted. And then interventions are put into place based on that. Some things that you can do to prevent falls. We know that if patients have all of the things they need right close to them, the call light, their glasses, a pencil, something to drink, those kind of things help to prevent falls. If we also are timely in taking them to the bathroom or helping them understand the bedside commode, we know that those kind of things prevent falls also. Also, if they have their glasses, a lot of patients, when they're in the hospital and they've been ill, they don't wear their glasses. So we need to be sure that they have those if they need them. Non-skid footwear. Um, just like back with Nightingale, the environment of our patients' rooms are our responsibility. Are they going to trip over the IV cord of the IV fluids? Are they going to trip over the cords for the IVs? Are there a lot of things cluttering up the room? Um, and then things about locking wheelchairs and things that you've known since you were in 231. The next thing we're going to talk a little bit about is seizures. Seizures have to do, the big word is precautions. Patients are going to have seizures. What are you going to do in a precautionary measure to be prepared if your patient is at risk for a seizure? Well, you're going to pad the bed, and then you're going to have rescue equipment that is in the room close to where you need it. Oxygen, an oral airway, suction equipment, and sometimes a saline lock so that you can give meds. Um, you need to be sure that any patient who's at risk for seizure has someone ambulate with them, that they're never allowed to get up and walk alone, and that everybody knows don't put anything in their mouth except that oral airway, no tongue blades or anything like that if they have a seizure. No one should restrain the client who's having a seizure, but help them lay on their side, put pillows around them, help to protect them until till the seizure is over, and then stay with them so that they don't try to get up and help call for help. And then of course document all the pertinence about the seizure: when, how long, how the patient behaved, how they were before and after, any injuries that they sustained. So documenting what interventions were put in place by you while the patient was having a seizure. Our next leading safety priorities are seclusion and restraints. Seclusion and restraints have become a very large, controversial area. I know you probably got a lot of that from mental health, when you know that in this day and age you cannot use medications to restrain your patient. There are very strict rules about what you can and cannot do, but sometimes patients have to be put in seclusion for their own safety or the safety of the staff, or they need to be restrained. Um, a lot of risks have been associated with restraints, such as asphyxiation and strangulation. If they are not used properly and patients are not assessed and cared for and watched all the time. They also can get such complications as immobility, pressure ulcers. They can have urinary and fecal incontinence and get pneumonia, depending on how long they're in these kind of restraints. Legally, if you do not follow the right procedures and protocols, you can have you can be charged with false imprisonment. And so you need to know the guidelines and the rules for the units that you work on that may use some kind of restraints or seclusion. They usually are ordered for the very shortest duration as possible. But one thing is that most of the time, you only can put restraints on without a physician's order in an extreme emergent situation. And then within 1 hour, that physician who's ordered it has to come in and do a face-to-face assessment. The order for restraints or seclusion, restraints mostly, have to be redone every 24 hours. And you have a responsibility for assessment every 2 hours. That includes circulation, sensation, and mobility. You also need to look on page 80 in the ATI book because there are a lot of things like offering fluids. Be sure that you provide for hygiene and elimination, monitoring their vitals, doing range of motion. Be sure and read all of those things that are required that you do for a patient who's in restraints. Also, that you understand a quick release knot and where to tie it to the bed frame so that it does not have any chances of strangulating your patient. And then what do you document? There are specific things that must be documented. Behavior, and it's very prescribed today about what we have to document legally. The behavior or precipitating event that made it necessary. You have to be sure that you document why it was necessary to put those on. Any attempts to use alternatives. The client's level of consciousness, what kind of restraints you used, education and what you did, and talk to the family. The client's behavior, when they were put on, when they were taken off, type and frequency, all the cares that you did Q2 and throughout the time the patient was in restraints. And then any medications that you administered while the patient was in restraints, all of that needs to be documented. The last couple of things we're going to talk about in safety is home safety. And one thing I think I left off of here is fire safety, so I want to talk about that for a minute. In fire safety, you need to know 3 things specifically. First of all, RACE. What do you do first? Rescue, alarm, contain, and extinguish. The first thing you always do is rescue your patient from wherever that fire is at. The next thing is you need to know the difference in the fire extinguishers, what a Class A, Class B, and Class C will do, which ones you don't use for which one's for electric, which one's for paper. And PASS, pull, aim, squeeze, and sweep, so that if you're the one who has to put the fire out in the garbage can or in the patient's room somehow, you know how to use the fire extinguisher. All units and hospitals have evacuation plans. So if you have to evacuate your unit, where do you go? And who goes first and how do you get them there? That's usually part of your orientation to the hospital. So be sure that you know that. And I can tell you that there usually are fire drills. Just like we have fire drills at school, only the fire drills on the unit, are different. It's to see if you know how to find the fire and shut the doors and get the patients out of the room and those kind of things. And then, so those are practiced routinely throughout the hospital all year long. So let's talk a minute. As nurses, as home care nurses, we're also responsible for home safety. The same thing, risk of injury. We're responsible to assess the environment based on the age and developmental level of the people who are in that home, anywhere from the infant, child, adolescent, adult, and older adult. And on pages 82 through 84 in your ATI book, it says specifically what each age group or developmental level is at the highest risk for, like aspiration for small children and infants from things they pick up off the floor, suffocation, things like that. Be sure you read through each and every one of those. Also, we need to talk to our families when we're there about a home safety plan. Does everybody in the family know what to do if there's a fire in their house? Do their fire extinguishers work? Do they know where to meet? Do they have a safe place in the basement if there's a tornado? Or do they all know to go to the bathroom, the inside bathroom, because they don't have a basement? So a lot of education and teaching is done in the home environment depending on the risk for injury for the age group and about having a home safety plan. Home safety plans also have to do with things like home oxygen if it's in use in the house? And do everyone know not